Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Today we are discussing the important syndrome that is hemolytic uremic syndrome. This entity is very important as per clinician point of view and exam point of view. So, the important thing, HUS is the leading cause of community-acquired acute kidney injury in children. So, all the cases of AKI in children, HUS should be one of the consideration. Okay, this is thrombotic microangiopathy spectrum disorder. What disorders are, we will discuss in some time. Okay, this is characterized by clinical triad, that is microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. Basically, what we discussed, the spectrum of thrombotic microangiopathy. First, we discussed hemolytic uremic syndrome, which is the star topic of today. So, we will discuss later also. HUS is being classified as conventional HUS and atypical HUS. So, conventional HUS is due to Shiga toxin induced E. coli HUS. So this is the most common HUS. More than 80% cases of HUS are found in this variant. Atypical HUS with dysregulation of alternate complement pathway due to pathogenic variants. Many alternate complement pathway disorders are contributing in atypical HUS. Okay, this is one of part. Other part like TTP, ADAMST13 deficiency. This may be due to acquired causes, this may be due to congenital causes. So this is one of the differential diagnosis of thrombotic microangiopathies. Are there any other causes for this? Yes, other causes are bone marrow and solid organ transplant, malignancy, sepsis, autoimmune disorders, drug, malignant hypertension, pregnancy, HELP syndrome, HIV infection, streptococcus infection, cobalamin C defect, and DGKE pathogenic variant. So this is very important. This spectrum of thrombotic microangiopathies contains HUS, which is most common cause, then TTP is another entity, and other disease, systemic disease associated with this condition. So just keep in mind this is a broad entity. Okay, coming back to HUS discussion. So HUS can be classified basis on underlying cause. Infection associated HUS. So the most common cause is Shiga toxin producing E. coli. 90% cases of childhood HUS are associated with this infection. Primary cause E. coli 0157H7 strain is very important. Other strains are also there, but just remember this particular strain is very important, and more than 90% cases STEC is involved. Okay, so how they get transmitted, that is important. So any thing which is contaminated by Shiga toxin, Shiga bacteria will give rise to infection associated hemolytic uremic syndrome. Undercooked meat, it may be unpasteurized dairy products, contaminated vegetables, contaminated municipal water supplies, petting zoos, lake pools, and person-to-person transmission in child care or center or families. So these are transmission sources. Are there any other bacterial causes apart from the Shigella? Yes, Shigella dysentery type 1. This is common in our country, Asia and Africa. Streptococcus associated HUS. This is due to streptococcal pneumonia infection, and though its incidence are decreasing post pneumococcal vaccination, but still this entity is there. Other infections like HIV, influenza, and HUS. We will discuss the causes in tabular format also, but as of now, just remember other bacterial causes are also there which can cause HUS. Okay, next entity. The genetic or atypical HUS. In this condition, no infective causes is found. It is non-diarrheal and this is hereditary form of HUS. Okay, so what are the genetic mutation associated with it? Deficiency in complement regulators like factor H, factor I, factor B, von Willebrand factor cleavage protease, that is ADAMST13, and cobalamin C defects. Just remember these genetic mutations. These are very important for exam point of view, like complement regulator factor H, I, B, von Willebrand factor cleaving protease ADMEST13 or cobalamin C defects. Is this autosomal dominant or recessive? It is both. It can behave as autosomal dominant and autosomal recessive. Clinical features can present without diarrheal prodrome as we seen also, but it can be triggered by infection. So atypical HUS is not per se due to infection, but it might get triggered by infection. Okay, are there any systemic disease associated with it? Yes, many systemic disease causing microvascular injuries like malignant hypertension, SLE, EPLA, post-organ transplant. Drug-induced HUS, yes, they are. We will discuss what drugs are included in this causating factor of HUS in tabular format. Okay, so this is important table discussing all important possible etiopathogenic mechanism or the pointers for HUS. So first thing, the diarrhea associated HUS. Okay, in this we have discussed STEC, E. coli and non-STEC Shigella. Okay, so this is most common. This entity itself contains 90% of cases. HUS secondary to systemic infection we have discussed streptococcus, HIV, influenza, herpes 6, parvovirus and malaria can also produce HUS. Atypical HUS due to complement dysregulation we have seen factor H deficiency, factor I deficiency, factor B deficiency, complement C3 deficiency, anti-complement factor H deficiency. So these are the atypical HUS due to complement dysregulation. TTP inherited ADAMST13 deficiency and acquired deficiency. Pregnancy associated with vitamin B12 deficiency. These are important considerations where we are thinking broadly. Okay. Next, what are the drugs that can cause HUS? Yes, just remember cyclosporine, tacrolimus, bleomycin, cisplatin, cocaine, and anti-VEGF drugs. Are there any systemic disease associated with? Yes, we have discussed earlier also. SLE, malignant hypertension, malignancies, cobalamin C defect, and other disease can cause. Transplant associated, yes, stem cell transplant, bone marrow transplant, renal transplant, heart transplant, and intestinal transplant, basically any transplant. So this is broad etiologies of HUS and similar looking thrombotic microangiopathy, just keep in mind. Okay, so what is the pathogenesis behind HUS? We don't do kidney biopsy, it is actually risky. So just normal finding like endothelial swelling, capillary wall thickening and glomerular sclerosis is seen. We generally don't perform kidney biopsy at all. Okay, so what is the pathogenesis? This is important. Okay, so the basic behind, just remember what is the basic. HUS leading to microvascular injury and endothelial damage leading to thrombosis, hemolysis and AKI. This is in brief how HUS pathogenesis works. Okay, first we will see the common variant STEC-HUS. Shiga toxin enters in bloodstream. It binds to endothelial cells, especially kidneys. It produces direct damage plus platelet activation and thrombosis. So this is basically direct damage to kidney endothelial cells. Streptococcus associated HUS neuraminidase from as Streptococcus pneumoniae cleavage sialic acid and it exposes Thomson-Friedrich T antigen. IgM antibody binds to it and it produces hemolysis positive Coombs test. This is very important. In Streptococcus pneumoniae HUS, the Coombs test is positive due to neuraminidase from S. pneumoniae cleavage sialic acid that expose Thomson-Friedrich T antigen that binds to IgM antibody and produced direct Coombs test positive. Next, we'll see atypical HUS, genetic defects in complement regulators. We discussed them earlier also, factor H, I, and B, that causes impaired complement inactivation, uncontrolled endothelial damage. HUS secondary to systemic disease is due to uh, like hypertension, SLE drugs, microangiopathy it will cause. So just see overall what these different etiologies do to the kidney or endothelium. After that, the common pathway, final common pathway, the kidney is damaged. So glomerular endothelial injury leading to localized thrombosis. Any cause, like it may be typical HUS, it may be atypical HUS, it may be pneumococcal associated HUS, it may be drug induced HUS, everything leading to glomerular endothelial injury that leading to thrombosis. Progressive platelet aggregation causes conjunctive thrombocytopenia. So which thrombocytopenia is found in HUS? It is conjunctive thrombocytopenia. Why microangiopathic hemolytic anemia develop? Because RBC distraction in damaged microvasculature is found. So this is final common pathway in all form of HUS. So what are the clinical features in HUS? Just see if it is STEC HUS, the common variant, the watery diarrhea will be there, progress to bloody diarrhea. So this is a common thing. Classical triad we know microangiopathic hemolytic anemia, thrombocytopenia, AKI. So just remember pallor, fatigue, jaundice, and schistocytes on smear. If any diarrheal patient you found this sudden onset of pallor, fatigue, jaundice, and cystocytes on smear, just once think of HUS in the mind and AKI also. So how you will diagnose? Mostly it is clinical and some laboratory parameter diagnosis. So hemolysis is occurring, so you will obviously found HB will be decreasing, heptoglobin will be decreased, LDH will be increased, and negative direct Coombs test except pneumococcal associated HUS in which DCT is positive and thrombocytopenia is there due to conjunctive platelet consumption. Okay, AKI markers you will see create one will be increased. Peripheral smear we discuss cystocytes, helmet cell, fragmented RBCs will be seen. Stool culture, yeah, it is not important, can be done. How you will manage this HUS? Supportive care is the mainstay of treatment. Okay, you have to manage fluid and electrolyte, manage, you can do dialysis if severe AKI, blood transfusion, hypertension control, avoid platelet transfusion. This is very much important. It may worsen thrombosis. Okay, avoid antibiotic and anti-motility drugs in typical HUS. This is very much important. So this is the key point of today. Avoid antibiotic and anti-motility drug in STEC HUS. This may increase toxin release. Eculizumab, it is anti-C5 monoclonal antibody. It used in complement-mediated atypical HUS. So the typical HUS mortality is 3 to 5% and long-term risks are involved. Obviously, atypical HUS has worse prognosis. Okay, so as we are discussing continued clinical manifestations, so typical HUS basically diarrhea prodrome is there and it is most common in preschool and school age children. So prodromal phase starts from 5 to 7 days before HUS onset and not all infected patients develop HUS. This is important and the practical consideration. So HUS onset, when you will mark HUS onset in a acute gastroenteritis patient, if patient, we have discussed earlier also, if patient develops sudden onset pallor, weakness, lethargy, indicating microangiopathic hemolytic anemia, patient having oliguria and fluid status variation might be dehydration or volume overload as per treatment status of that child. Okay, pneumococcus associated HUS, diarrhea will be not there, but pneumonia empyema will be there. Atypical or genetic HUS, these are insidious onset triggered by mild infection. Okay, so in severe disease, leukocytosis, hyponatremia, antibiotic use will be there. Renal complications, dialysis is required in 50% of cases in usually in 2 weeks. So this is actually morbid condition. Okay, cardiovascular complications can be there due to fluid overload condition. Neurological complications might be there due to hypertension, other issues. Severe CNS involvement is seen in less than 20% cases due to seizures, focal ischemia due to microvascular thrombosis. An important consideration, basal ganglion cerebral cortex infarction. Yes, they may occur, but yeah, these are very less frequent phenomena. Hypertensive encephalopathy obviously can occur. GI manifestation, all we know. Hematological complication, all we know. Okay, so how you will diagnose? So just you will see this is simple. This is you have to see the triad, and on the basis of triad we can diagnose it. So laboratory finding we have discussed anemia, negative comb test, and thrombocytopenia. Coagulation studies. This is very important. In this settings, DIC can work like this, but in DIC, the coagulation studies are abnormal. On the contrary, HUS coagulation studies are normal. Okay, kidney function test, analysis. Okay, stool culture you can do, but it may be negative. Only 10% of typical HUS patient developed the typical STC patient developed HUS. Okay, genetic testing you can do if other things are there. Okay, so this is important. So how are there any differential diagnosis for HUS? Yes, this is very important. Just remember thrombotic thrombocytopenic purpura TTP. In this, more neurological deficiency involvement and due to ADMST13 deficiency, very important. SLE autoantibodies will be there. Obviously, malignant hypertension, severe hypertension is primary event. Bilateral renal vein thrombosis associated with nephrotic syndrome, absent hemolytic anemia, and DIC, as we discussed earlier, also coagulation profile will be deranged. So these are the differential diagnosis of HUS. You can easily differentiate them by looking the overall clinical picture. Okay, role of kidney biopsy. The kidney biopsy role is very rarely needed. If it is needed, then atypical presentation, unclear diagnosis. Okay, so the prognosis is diarrhea associated HUS mortality rate less than 5%, acute dialysis requirement around 50% of patients. That is very important. Recovery pattern, platelets recover first, renal function follows, and anemia resolution occurs in last. Okay, and 5% remain dialysis dependent. So this is very important statement. Platelet count recovers first, renal function recovers follow, and anemia regulation occur in last. Okay, so pneumococcal associated, we have seen this having higher morbidity and mortality rate. Okay, so we discussed the treatment. Once again, this is supportive. Okay, RBC transfusion. RBC transfusion may be required due to brisk and recurrent hemolysis. We should give washed RBC to remove residual plasma. This is very much important. Platelet transfusion generally contraindicated due to consumption of transfused platelet except the life-threatening bleeding. Are there any specific therapy for HUS? Therapies are not recommended as such. Just remember, anticoagulant, antiplatelets, and fibrinolytic therapy are contraindicated due to high bleeding risk. This is very much important. Antibiotics in the case of typical HUS generally contraindicated. Just mark this statement, and this is important for your practice also. What are the exceptions for antibiotics? Azithromycin is used in adults, and in adults other antibiotics like meropenem, rifaximin and azithromycin. Three antibiotics are used. Generally we see antibiotics are not recommended in HUS, but in adult studies meropenem, rifaximin and azithromycin are used, but not in pediatric population. Okay, plasmapheresis is used in uh, STEC and HUS, but it's no proven benefit. Just remember, plasmapheresis or plasma infusion, it is contraindicated in pneumococcal HUS, may worsen disease progression. This is very much important. Okay, so plasma exchange or plasma infusion, it is considered in which condition? Severe non-STCHS with CNS involvement. CNS involvement, if there you can do this, and beneficial in complement related HUS like ADMA-ST13 deficiency or factor H deficiency. So the plasma exchange or plasma infusion, actually you don't do this in pneumococcal HUS, but you can do in complement related HUS and in severe typical HUS with CNS involvement. Okay, so Eculizumab, the star thing, anti-C5 monoclonal antibodies. This is used for atypical HUS, but the question again, prerequisite meningococcal vaccination is due to is very important. You have to give. Okay, so yeah, long-term follow-up generally they recover, and persistent abnormalities at 1 year post episode may be seen. Okay, so follow-up recommendation like hypertension, you have to screen BP annually, proteinuria, urinalysis annually, chronic kidney disease, you have to see creatinine and eGFR if abnormal, neurological sequelae like cognitive neurological impairment. So just revise this topic. The guideline has been revised also. This is very important topic. Just go through this video again and see the important concepts and recommendation of treatment in hemolytic uremic syndrome. Hope you will and hope you enjoy this thorough discussion on HUS. Euconium Elias will discuss some another topic of this amazing series. Till then, do share, like, and